Hi everybody and welcome to our very special session at the Festival of Public Health. We're so pleased that Professor Graham Lord, who's our Dean of the Faculty of Biology, Medicine and Health, and also Vice President of the University of Manchester, is able to join us today. We have a fantastic lineup of our dissertation students from the master's programme. And most importantly, we have you, our delegates, to ask questions of how we're doing with our research and teaching in public health. Just a few housekeeping rules. For delegates, please could you have your microphone and your video on off, and also we'd like to encourage you to use the chat function to ask questions of our panelists. We are recording this and we will be putting it onto our YouTube channel, and if you have any questions, please again use the chat function in Zoom. So without further delay, I'd like to introduce Professor Graham Lord and ask him to take the stage. Thank you, Graham.
Brilliant, Arpana, and I'll take the virtual stage without moving an inch from where I was. So it's a great pleasure to be, an honour actually, to be invited to speak at this session today. And Arpana and I were reminiscing just before the session started about the Festival of Public Health in 2019 that I think I gave an opening address to and spoke on the same platform as Tim Newton. And we were thinking, actually, that's the last time we had this Festival of Public Health, and about how much had changed since then. Little did we know in July 2019 what was about to unfold in front of us. So I think what's important to say before I sort of get into a few slides about what our response to COVID-19 was across the university, and in particular the faculty that I'm privileged to lead, is just to say thank you to Arpana for putting this together. This is the 9th year of the International Festival of Public Health, hosted by the Manchester Urban Collaboration of Health. And it's such, if it was not thought of as a sort of centre of all of the faculty's thinking in 2019, the last 18 months has shown us how important research in public health and the passing on of that knowledge via teaching is during COVID, and actually even more importantly about how we respond to the unfolding sort of headwinds and tailwinds of the pandemic. So I know that's probably what you've been talking about the last day or two, and we'll be talking about over the next day or two as well. So let me tell you what we try to do as part of our contribution to COVID-19. So I think the first thing to say about the University of Manchester, it has three almost sort of equally sized faculties. We have a Faculty of Humanities and Science and Engineering. And actually at around February and March, what we decided was to coordinate all of our activities from the university into a research rapid response group. And we framed this around the governance structure of our Academic Health Science Centre, really with a focus on saving lives in the NHS and in social care, prioritising research programmes, and actually making sure that we delivered impact both immediately and into the future. And these things are always very challenging. We had lots of discussions with our Institute of sort of Conflict Resolution, because a lot of people wanted to come forward and help, which is understandable in a crisis of this proportion. And it's really hard to coordinate all of that into a focused response. So clearly it wasn't just our university. We worked in very, very close partnership with the NHS and Health Innovation Manchester. And as I said, we utilised our Academic Health Science Centre, which we'd just been reaccredited for 5 years. I think we found out about a week before a pandemic was declared by the World Health Organization. And also this was, an international effort as well. We collaborated closely with colleagues from Wuhan and across the UK as well as more broadly across Europe. And I think before I will move on to some of the, the faculty specifics, I think what was extraordinary, and I suspect this was is similar across many other cities and countries across the world, is how collegiate everybody was and how everybody sort of pulled together to really focus on mitigating the healthcare disaster that was unfolding in front of us. And also that despite that pressure test of our system, what it's actually done is it's driven us close together. So I think one of the positive outcomes, despite many negatives of the COVID pandemic, was this close collegiate working and realizing that we all deliver far more as a team than as any individual. And I think that will last, hopefully, a long time beyond the current pandemic. So across, as I mentioned, we have 3 sort of broadly equally sized faculties, all within quite sort of close geographical proximity. The faculty that I run, Biology, Medicine and Health, looked at everything from fundamental biology of disease all the way through to prevention and treatment. As I said, humanities, where our sort of conflict resolution institutes sit, and many other sort of major, world leading centres, we work very closely to apply our understanding of society and culture. And I know it's you had a session this morning about the societal determinants of health, and we all know, certainly in the public health world, and I'm sure you're all far more aware of this than I am, that actually the social determinants of health are even greater than the biological determinants of health, and actually we ignore that at our peril. And that's exactly where public health sits, at that intersection. And then equally, we had fantastic contributions for our Faculty of Science and Engineering through mathematical modelling, which informed direct and immediate healthcare decisions about ICU capacity, bed capacity across Manchester. Also, we utilised our 3D printing department to print PPE. I'm sure you remember in the early days when PPE was in very, very short supply, and our 3D printers turned them on and were printing visors and personal protective equipment for our frontline staff. A really heroic effort. So I said we set up, over a weekend. It's the most rapid piece of research governance I've ever seen. And again, congratulations to everyone that pulled it together. This Research Rapid Response Group. It was established, led by the university and led by myself and others at the faculty to coordinate our research input, as I said, into the frontline healthcare scenario, so that we didn't cause more problems than we solved. And we had to link in with many NHS trusts across Greater Manchester, also linking in with national priority areas defined by the National Institute of Health Research, and actually rapidly redeploy many of our research staff out into the wards and the intensive care units across the city, so that there was capacity to deliver on the clinical trials and the research that I'm going to describe to you. And here I would like to particularly thank, and I think you may be talking sometime this week, Ian Bruce, who's the director of our NIHR Biomedical Research Centre, who was pivotal in delivering many of these programmes, and also Peter Clayton, who's the Deputy Dean, who is the clinical lead and the clinical director of the Manchester Academic Health Science Centre. The other thing that I'll mention before I move off this slide is Health Innovation Manchester, led by Ben Bridgewater, did an enormous piece of work about linking up data sets across the whole of Greater Manchester, such that, within about 3 months of the pandemic, we had almost 90 to 95% coverage of people across Greater Manchester through the Greater Manchester Care Record. That helped us track many of the adverse outcomes of the pandemic. And again, this is a positive legacy moving forward that we need to ensure that we build upon. So our areas of focus really within the RRG, as we called it, were new treatments and clinical trials. And I'll go into some of that detail on subsequent slides. Again, understanding fundamental disease mechanisms. People will recall in January and February, this was a totally unknown virus, and nobody knew which organ systems of the body affected, how you treated it. And so that understanding of that fundamental biology by a rapid on-the-fly setup of a Greater Manchester cohort has proven very informative, and continues to do so as we model the pathophysiological basis for long COVID, for example. I've mentioned the disease modelling and the health informatics. with the Health Innovation Manchester, and also from our Department of Computer Science. And many of these disease modelling areas have fed directly into SAGE, and I know our partners advise SAGE as well. So we, as well as utilising these research skill sets for local management of the pandemic, we also ensured that any learnings that we had were scaled and informed national decisions. And clearly epidemiology, mental health, social care and public health is what we're talking about at this festival. As I said, of fundamental importance then, as it is now, and even more so in the future. We did a lot of research on patients with existing health conditions, whether they were renal transplant patients, whether they were patients with autoimmune disease on immunosuppression, patients with comorbidity and chronic other chronic diseases. And you will have seen from a number of reports that people like Luke Mumford from our applied research collaboration, in collaboration with scientists in Newcastle, have shown the increased morbidity and mortality across the Greater Manchester population, in large part due to pre-existing health inequalities. And I'm sure you'll be discussing this week about how they were brought into stark relief during the pandemic and continue to widen. And it's really incumbent on all of us here to understand what the key drivers of those are, but more importantly, what the interventions are we can make in a sustainable manner to change that. We led a number of national trials through the Condor programme with Rick Boddy about diagnostic sort of A&E point of care. And again, looking back, it was remarkable, people turning up in A&E not knowing whether they had COVID or not, and how you drove these points of care diagnostics for rapid decision making. And that was a very successful programme and continues to help us understand what point of care diagnostic will look like, particularly as we move into the autumn and the winter, where we're going to have to understand multi-parameter testing for COVID and flu and RSV, all in real time and all points of care. We've led Andy Ustanowski, who's an infectious diseases doctor in North Manchester, has led and is leading on all of the vaccine trials from Greater Manchester, and is also the national lead for vaccines via the NIHR. And as I've mentioned, organisational development and decision making through collaboration with our Healthcare and Conflict Research Institute, and also links into global health through our African Cities Initiative, truly a GM-wide initiative here, and also collaborating with the other universities within Manchester as well. So just a few words about some of the projects that I've mentioned to inform these high-level ideas with some specifics. The biology of understanding the mechanisms of disease and the immune response. It became apparent very early on that a lot of the morbidity was caused by an exaggerated immune response, particularly in week 2 of the disease. It was, mortality and morbidity was rarely caused by the initial insult, viral insult to the airways. And so we did a lot of very detailed work around that, particularly Tracy Hustle's group that I'll talk about on the next slide, in terms of how we applied our efforts and our capacity to treatment during the first wave of the pandemic from March to June and July. We applied much of our clinical research capacity to the recovery trial, and per capita Greater Manchester was the biggest recruiter to the recovery trial, which, as I'm sure you'll all know, was the description and the proof that dexamethasone given early on reduced mortality from COVID-19. And as I've said, we're contributing to a large number of national research platforms where we can't answer the question ourselves, particularly around long COVID and the FOSS COVID study being led by the University of Leicester. And I think that's the other thing that I would highlight, is that where Manchester has specific expertise or specific problems that are important to our local population, we will solve those. But actually, we're also, importantly, a very strong participant in national initiatives. And I think Greater Manchester, I'm very proud to say, played its full part in our national and international response to COVID. As you're discussing this week, the public health consequences of this disease was, is, and will be devastating. And I know some of the talks that will come after mine will be specific. You will talk into some of the specifics about how we're addressing that. and particularly looking at mental and physical well-being during lockdown and after lockdown. And then the most important, I think, is the effect of COVID within communities, and how that differs between our different communities. And we've put a huge amount of effort into patient public involvement and engagement, and talking to patients and the public about their perceptions of disease, understanding in response to vaccination, and how we work this through as people come through with morbidities and comorbidities after the pandemic is going to be extraordinarily important. So just and you know, most of these data were published very early on, actually, that the mechanistic study that was led by Tracy, who's the director of our Lydia Becker Institute of Immunology and Inflammation, helped us to see in real time what the virus was doing to the human immune system. This was truly a sort of a broad Greater Manchester Alliance effort, which was really the first step in understanding how to treat it, and inform many of our early treatment decisions, as describing a sort of biomarker of response, which patients were going to get severely ill. And actually, really importantly, how many of these acute findings, and particularly for the immunologists in the audience, if there are any there, monocyte activation and persistent monocyte activation, how this links to disease burden and symptomatology of long COVID will be really critical to understand. And there's ongoing work following this cohort through, as they recover or not, or develop symptoms as we go forward, in terms of informing how we might treat this long COVID disease, which is, as you will know, largely undefined pathophysiologically. There's still a lot we need to understand about the fundamental biology. And you'll be hearing, if you've not already heard, about the impact of social distancing on mental health. Our psychologists within the School of Health Sciences that our partners division sits in have looked very, very carefully and confirmed how this loss of social interaction impacts physical and mental well-being, and actually is providing evidence about how people will behave as lockdown is now ending. And that's important in terms of understanding how COVID might continue to spread. And I think, unfortunately, over the next few weeks, we will see increasing case rates, and I suspect they will disproportionately affect certain sections of our society to their detriment, which is of great concern to all of us. We also worked early on, and we still continue to work about which part of the coronavirus is a good target for vaccines. And there's been a lot of work about on next generation vaccines that we hope will be deploying in Manchester in the near future. As you know, at the moment, many of the vaccines are focused on spike, and I think in terms of preventing aberrant responses or vaccine escape from variants, I think there's also a consideration about what we do about the next coronavirus pandemic or epidemic, which is only a matter of time. But we've done a lot of work on that within the faculty. And actually, again, from fundamental biology to important impact on our ageing population, the University's Healthy Ageing Research Group teamed up with the Greater Manchester Ageing Hub, so a really good linkage with sort of local council and local support here to look at and how we support people who are self-isolating during COVID-19, and actually resulting in a real practical outcome that was distributed across Manchester about how people could keep well at home during a lockdown. Very important. Kevin Munro, again within the School of Health Science, was led and is leading a national programme on the long-term impact of COVID on hearing among people who have been previously treated in hospital with the virus. Early on, it was recognised that certain aspects of sensation, particularly loss of smell and loss of taste, were an early sign with COVID, but actually Kevin's been leading on other areas of the impact of coronavirus on our sensory systems and hearing as well, really sort of world leading. And also continuing sepsis and COVID-19, Paul Dark, who's one of our clinical academics, who's now also a national lead. He was promoted to be national lead of the ICU consortium by the NIHR halfway through this, as the chief investigator of this national ADAPT sepsis study looking to improve the use of antibiotics in patients with COVID-19 who are at risk of sepsis as well. So I hope that gives a bit of a flavour of how we contributed and how we continue to contribute. And I'll leave it there, but I'm more than happy to take any questions. So I'll partner back to you if you're emceeing the session.
Thanks so much, Graham. And I think a lot of the work that you've described here, as you say, are so important both nationally and also internationally, because a number of our students and delegates are from our international settings as well. So I just wondered, Graham, if you could give us some heads up, because I know you sit on national panels as well, with the current situation of funding for research, where the next big thing is for the pandemic funding, and then also as we see beyond the pandemic, what your thoughts are going forwards in terms of where we as public health, either researchers or professionals, should be looking at?
I mean, very important questions that everyone is wrestling with at the moment. I think one cannot get beyond the economics or the economic situation that we find ourselves in at the moment, both, you know, within funding councils and the sort of UK at large. I'm sure that what we've done as a community is demonstrate the importance of real-time research into impact, and one might hope that the government understands that, and they do, but can find the fiscal headroom to continue to support this. As I mentioned in the talk, and we have much data now published, and a lot of the work I know has come out of the work that you've done, Alpana, and others at the university, and more widely, as I said, about the pre-existing health inequalities that were here within Greater Manchester, but also other regions as well. Obviously, we focus on GM because that's where we are, and how those fissures were exposed during COVID, and what we do about them, I think, is going to be really quite important. I think the government understands that. I think they don't understand what to do about it. So I think going forward, the key role of public health is to obviously describe that and understand the drivers of that. But I think we've been doing that for quite a long time. I think we know what the drivers are. I think what we need to understand is what are the economic, financial, and health delivery sustainable solutions that can change that direction of travel. And I think that's what public health needs to solve. And I think it's the greatest challenge of our time. And whether that's directly related to COVID in, you know, either new acute infections, which disproportionately affects certain members of our community, and we now understand what they are, and we're starting to understand what we might do about it, what the overhang of long COVID is, and is there a disproportionate effect there, and how do we treat it? But actually, how do we understand, again, those, how it impacts people with comorbidities, whether that's mental health, whether it's cardiac disease, whether it's pre-existing respiratory disease, all aligned with, you know, when you have that concatenated, if that's the right word, with poverty and poor housing and poor educational opportunities, that public health needs to grasp that and identify what interventions can we make and when can change the needle on that. And I think the groups or the universities or the academic health ecosystems like we have in Manchester that can test out those interventions rapidly and then scale them up internationally, that's where I think the funding needs to flow to. So I think great ideas about how we address this are really important, and hopefully by the end of your festival you'll come up with some good ideas around that. But again, I think that linkages of fundamental research with public health research, but actually with that wider reflection into the entire health ecosystem and social care that we've been working very hard on in Greater Manchester for the last, well, 10 years at least, and over the last 5 years are going to be really quite important, because you need to be able to implement interventions at scale if they're going to be sustainable. So I don't know if that answers your question, but
no, that's fantastic, and I think we've definitely come a few steps forwards in that vision that you have, Graham, in that we obviously have Sir Michael's report
yes,
for Billferry in Greater Manchester, and we spoke about if we could host bringing back Sir Michael and Jessica Allen, who's the Deputy Director, to actually put into action what the recommendations were.
yes.
And we've got Andy Burnham coming on Friday to see if we can link up all the different components within our Greater Manchester area to be able to bring that about.
And I think if you could do that as an outcome for this, that would be fantastic. I've been, for the last 12 months, been having discussions with Michael Marmot and others about founding an Institute of Health Equity. I know that means slightly different, but I quite like moving away from a deficit model of health inequality. And I'm absolutely passionate about equity in health and how we define that. And I think health is a very good lens, even though there are other drivers of lack of health equity. I think health is a good way of looking at that, whilst bringing in these other, as I said, drivers of housing and transport and poverty. And actually, I think Greater Manchester needs to have something like that, an Institute of Health Equity, where actually we talk to the populations most greatly affected, and our outcome is making healthcare more equitable in measurable and sustainable outcomes. And that requires not just a division or a school or one university, it requires a whole system and actually a whole community. And that's where we need to start, by talking to our patients and our population, which I know you and you have led on enormously, and you're to be congratulated for that.
Thank you, Graham. I think Isla has a question for you.
Yeah, I was just wondering what your opinion was on how the impact of this on the research process in terms of getting funding, doing the research and getting it published, which is obviously all really speeded up over the past sort of, 18 months. And I wonder what your views are on whether, how much we'll revert back to the previous method of doing things.
Yeah, no, that's a great question. And I think we're still in that phase. You know, obviously there are some people that think the pandemic's almost over, but I think most of us around this table will probably, hopefully we're somewhere halfway through it, but actually we might just be at the beginning of it. And I worry that actually we're sort of just at the beginning of it, despite, you know, Freedom Day or whatever we were supposed to call it yesterday. But we won't get into the politics of that because that'll get a bit contentious, I suspect. So what I really mean is what worked well in COVID and what would only work well in COVID, and how that now, what we capture from that and distill that into the sort of more heterogeneous, broad-based research activity that actually has been our strength as an ecosystem for the last 50 years in the UK. And I think there's a temptation to think, well, let's do everything like we did in COVID. But actually, in some ways, there was a very straightforward question, and there was one question. And so we all coalesced around that one question, which was appropriate. I mean, it was like a sort of a wartime effort. From March, but you know, the 12 months going on where we had no treatments, no vaccines, no understanding of the biology of the virus. I'm not sure all of that translates into what we need going forward. So I sit on sort of the oversight board for the sort of recovery, resilience and growth piece for the NHS and NIHR, and those are precisely the questions that we're wrestling with. We've put out a month or two ago, and I'm happy to say it's probably less than a month ago actually, a piece about clinical research post-COVID, about how we can maintain the rapid ethical review, the rapid MHRA approval, the good data linkages, and what that might mean to restart other clinical research. Because I think what we did really well during COVID was focus on one question, better than probably anywhere else in the world, to be honest. And that was through, you know, Chris Whitty's, you know, urgent public health approval thing. That was exactly the right thing to do. But as anything in life, your greatest strength is sometimes a weakness as well. And I think what we now have, not only a backlog of other research in the NHS as well as treatment, and it's how we get that restarted again. So I think there's lots of detailed discussion about what we preserve going forward. And I think there's also an issue of societal trust as well. I think there's a lot of people that think, oh, well, we linked all of the data together for the COPE notices during the pandemic, let's just keep it rolling forward. And you'll have seen some of the discussions about that. I'm not sure that's the right answer. I think there's a more nuanced approach to that. And I think we need a real sort of conversation with our communities about what they want whilst preserving the rapid review. Some of that's not sustainable, though. I think we have to understand sustainability. That's sort of my watchword for everything going forward, whether it's faculty finances or whatever. I think it's really important, and it's an often spoken word, but actually to have an ethical review, because you've got an ethics committee sitting every 48 hours that you can do during a pandemic, clearly that is not sustainable going forward. And I also think we have a workforce that is absolutely exhausted. So I think we just need to be actually steady and more thoughtful. So in some ways, revert back to that hypothesis, the standard approaches, but actually just make sure that the efficiencies that are baked into the system are sustainable and maintained. And I have confidence that we will do that.
Thank you, Graham. Might you be able to take a question from our dissertation lead, who's also our divisional social responsibility lead? Roger, over to you.
Hi, thanks Arpana, and thanks Graham. And I guess many of us feel very proud to be working at the university given the achievements that have been taking place and the rapid response that you outlined. I think what also deserves perhaps greater recognition is the extent that our students have also come together, not just in terms of the impact on their learning and curriculum, but thousands of our students have made direct contributions locally and internationally. And I think sometimes we overlook this huge resource of what do we have, more than 50,000 students, and they themselves can make fundamental impacts on sustainable changes to our communities, I think, particularly as we have more internationals. A recent example we'll hear on later is, nearly 18,000 face masks and PPE shields now have been supplied to Uganda through an organisation that I lead from students here in Edinburgh. And, I think that's a massive contribution. And that's just one example that I'd like the university to give more consideration to.
Yeah, thanks, Roger. Thank you. I just respond to that briefly. I think thank you for mentioning in that, and I could give a whole other talk about our student contribution, and actually in many of the communications I've given, I've highlighted that, and right from last May, June, we graduated a lot of our healthcare students early, in the teeth of the pandemic, nurses, midwives, allied health professionals, doctors, dentists, and actually got them out literally onto the front line. And that was an extraordinary achievement, not only of the students, but the staff that taught them and got them over that line. As you say, Manchester has a very proud tradition of social responsibility through its students, whether it's our dental students going out and giving dental treatment to people who don't have homes to live in. I think our students have been extraordinary. In fact, I just found out this morning, so don't broadcast it more widely, I'll get into trouble because it's not the public domain yet, but actually our student volunteers for vaccination has just hit 1,000. So our students are extraordinary and have stepped up and have actually worked with us as we've had to transition to online working, and for the most part been completely understanding of the challenges that we've all been working under. So you're absolutely right to pull me up on not making specific mention of that, Roger, for which I apologise, but I hope I've made up with some of those comments, and also all of my previous communications where that has been highlighted as well. Thank you.
Thank you, Graham. We do hope you'll be able to stay on, but I know how difficult it is at the moment. So can we take this opportunity to thank you again for your leadership, and also for presenting here today. It's meant a lot to both the staff and students and our delegates. So thank you, Graham.
You're welcome, and thank you for inviting me. I feel very honoured. Thank you.
Thanks. I'd like to invite Caroline Headley.
Hiya.
Hi, Caroline.
I'll just share my screen. Okay. Can everyone see that?
Thank you. Yes.
Brilliant. Okay, so yes, hello, my name's Caroline Headley. I was a student on the Masters of Public Health last year, and this is a public health report I wrote on an investigation into the factors associated with lower MMR vaccine coverage rates in London and recommendations to address these factors. So this graph really illustrates why a national measles, mumps and rubella vaccination programme is so necessary. So you can see before the measles vaccine was introduced into the UK, and then later the MMR vaccine, you had about 160,000 to almost 800,000 cases of measles per year in the UK. And now this is about fewer than 1,000 cases per year. And it's really important because measles is highly infectious. So the reproduction number, which I'm sure we've all sort of heard a lot about because of COVID, is about 15 to 17. So it's the most infectious disease known to man. And with mumps and rubella and with measles, there are some really serious complications. So for example, fetal abnormalities and neurological complications as well. But thanks to the vaccination programme, measles, mumps and rubella, so the incidence of these have greatly reduced. So in terms of the MMR coverage rates, this shows the MMR coverage rates in England between 1988 and 2019. And this is the first dose of the vaccine. So there are 2 doses given. One should be at about 24 months and the second dose given between 3 years and 5 years of age. So just a few things to point out here. So the World Health Organization has set a 95% coverage target. So what this really means is that 95% of the population should be vaccinated in order to confer herd immunity across all age groups. But as you can see, in England, typically the vaccination rate has varied between 80 to 90%, so it's not quite meeting that target. If you see trend A in the graph, this is when vaccination rates dropped to their lowest level, and that was in response to the heavily publicised fraudulent links between the vaccine and autism after the paper published by Andrew Wakefield. Since then, rates have sort of increased again, and in 2018 to 2019, the average in England was 90.3%. So unfortunately, the rates in London are far lower. So you can see in this, on the left here in this figure, you've got rates in London lowest nationally, and they're far below the national average. So in 2018 to 2019, the rate of the first dose of the vaccine at 24 months was 83%, so significantly lower than the 95% target set by the WHO. And on the right here, you can see that London sticks out as an area where there is low immunisation coverage because it's that light blue colour. And in fact, only one local authority in the whole of London achieved over 90% coverage in 2018 to 2019. This is quite important because the burden of measles, mumps and rubella is also highest in the capital. So it's really sort of important that this is addressed this as an issue. So the aim of my report is really to understand the factors contributing to this lower MMR coverage rate in London. And so in order to do this, I searched key government websites, health and social care websites, and then also conducted a literature search of the databases Medline and Embase. So due to the nature of the research question and the paucity of the available evidence, much of the evidence came from smaller observational studies and reports from local authorities. However, what I found was 3 sort of main factors which seem to be contributing to these low rates. So these were the population in London, high population mobility, and actually how the MMR vaccination programme was delivered in London. And I'll briefly talk through each of these now. If my screen will move. So in terms of the population in London, language barriers might affect the immunisation service. So London is the region in England with the lowest proportion of people whose main language is English. And within local authorities, there's also quite a lot of variation. So for example, in Newham, the proportion of people whose first language is English is just over half, so 58.6%. And there is evidence from qualitative research that language is a barrier for certain communities which have been studied. So for example, Romanian and Romanian communities, this was a barrier in one study. It's quite difficult to understand exactly what these barriers are because they're highly specific to the communities. So one study included in a systematic review found that some Somali parents expressed concern that the link between autism and the vaccine disproportionately affects individuals from a Somali background. And again, as I mentioned, there is a lack of high quality evidence in the literature, but case studies from local authorities suggest that it's actually that the specific needs of certain communities haven't been addressed, which means that underserved communities are overrepresented in the capital. Another issue was high population mobility. So a 2017 audit found that 33% of infants living in London had moved at least once by the time they were 12 months old. And in London, the average rate of households in temporary accommodation is far above the national average, so 14.9 per 1,000 compared to the average rate of 3.4 per 1,000 nationally. And there is evidence to suggest that residential mobility is associated with a higher risk of not being immunised. And this might be due to practical barriers, so not receiving appointment reminders or unfamiliarity with services as well. So my last point was the actual delivery of the vaccination programme. So London is the only region without a dedicated screening and immunisation team. And this team really exists to facilitate delivery of the programme at general practice level. So London might face a distinct disadvantage without such a team. In addition, as you can see from this graph here, London has the fewest practice nurses per 100,000 compared to other regions of England. And this is important because it is practice nurses rather than general practitioners who are really responsible for the delivery, the day-to-day delivery of the vaccination programme. In addition, there are some issues with the standardisation of the call and recall system. So this is how invite reminders are sent out. And there's quite a lot of evidence to suggest that sort of not having a standardised call or recall system can lead or can be a barrier to vaccination as well. So finally, in terms of interventions and recommendations. So local authorities should tailor the immunisation programmes to the communities that they serve. And this might include translating vaccination reminders into the languages spoken into the communities, and also commissioning research into what the specific barriers are for the communities in that local authority as well. There's also some evidence from sort of pilot studies that enlisting local community leaders to provide information about the vaccination programme can lead to higher vaccination uptake. Secondly, to set targets for the number of practice nurses recruited in London, and this might help with the day-to-day delivery of the vaccination programme, because nurses can often run evening clinics and can perform home visits, which again have been shown to increase uptake. Thirdly, issue minimum standards for call and recall systems. A few pilot studies have been trialled in Wandsworth and Tower Hamlets, so two local authorities in London, and actually sort of standardising the call and recall systems led to improved outcomes, including higher MMR vaccine uptake. Finally, to address the high population mobility, sort of evaluating the feasibility of a centralised call or recall system might be of benefit. And certainly it's what's currently used for the national screening programme, so there is evidence that this is a successful strategy. This will also help to provide a more equitable service because children who move often won't be missed out from invite reminder systems. So thank you very much. That concludes my presentation. It's interesting because I wrote this dissertation, in the first lockdown, of the COVID pandemic. And the vaccination program is underway, but actually London, the rates of COVID vaccination in London are still quite a lot lower than the national average. So it's interesting to see that perhaps these findings aren't just specific to the MMR vaccination program. So thank you very much.
Caroline, marvellous. It's a shame we can't give you a virtual round of applause. Brilliant work, and we've got a few questions that relate to your last point. Graham wanted to know, are there areas outside of London that have similarly low uptake? And Roger wanted to know what can we learn so that we can increase our coronavirus vaccine program, because I'm sure you've seen the uptake in the younger age groups is far less. Do you have any thoughts?
Yeah, absolutely. So in terms of the first question, certainly London has the sort of most concentrated areas of low uptake. So I obviously could go back to the graph, but there were a few other points where there were sort of areas of light blue, but actually nowhere as low as London. And it's quite interesting because, for example, Manchester, a very diverse population, also Greater Manchester, quite a deprived population, has some really, really good uptake rates. So it's clearly a more complex issue than just sort of cities have this issue. And that's why so much of my recommendations were based around local authorities really doing the work at ground level to see the communities that they serve. Another thing is, yeah, the population mobility I think is quite specific to London, and that's why that was such a key issue. But it is astonishing that really does seem to be London that has the lowest uptake of them all, and actually in Europe, again, quite poor rates compared to Europe as well.
Thank you.
Thank you. And then, yeah, in terms of the second question, so I think, again, really doing the research into what the barriers to vaccination are. So I know that certain communities have expressed concern about the COVID vaccination and really addressing these. And again, perhaps enlisting community leaders to address these. So there was some evidence whilst I was doing my research that kind of having lay healthcare workers from certain communities could really boost uptake, and also sort of cultural awareness training and things like that, again, to just really address concerns. In terms of sort of the younger population, I know that this is currently being done actually, trialing offering vaccination in local parks and, local shopping centres. That was another sort of recommendation of mine, just trying to kind of boost awareness and sort of opportunistically vaccinate as well, rather than having to sort of rely on people taking time out of their day to go and get a vaccine.
Thanks, Caroline. One more question in the chat from MP about Wales and any further suggestions on increasing uptake that you have. Did you look at Wales data?
No, so that, yeah, I only concentrated on England, so I'm not entirely sure. But again, what was quite interesting to me was I sort of going into the dissertation assumed that it would be anti-vaccine sentiment, which would be the sort of the main finding, I suppose, or main reason why London might have low rates. And actually that was quite far down the list and wasn't one of the main factors. Often it was practical barriers. So maybe in Wales, the way the call-recall systems are implemented might be something, or the way that the vaccination program is actually delivered. Again, unfortunately, I haven't looked at it, so I'm not entirely sure, but certainly practical barriers seem to be the main issue.
Thank you, Caroline. We've got a couple more in the chat. I don't know if you're able to answer some of those queries. Yes. And we'll move on to our next speaker. But thank you once again for a fabulous talk, and really pleased to see this great work. So I'd like to move on to Manon. Hi, Manon.
Yes, hi. Shall I share my screen?
Thank you so much, and thank you for presenting. Over to you.
Yeah, is that working? Thanks very much, Caroline. That was a great presentation and very hard to follow. So, I'm Manon Williams, of no relation to Greg, if anyone's interested. and I'm presenting my dissertation, which is on the usefulness of anticoagulants in the treatment of COVID. And this was a systematic review. So, blood clots and COVID. Why was I interested? Well, on March 11th, as we all knew, the COVID pandemic was announced. And not long after, reports started coming out of a link between blood clots and COVID. These are ones from April. And indeed, in the end of last year, a systematic review showed that out of 8,000 patients studied, venous thromboembolism, VTEs, were at rates of 21% in hospitalized patients with COVID. And amongst ICU patients, these rates were as high as 31%. And this affected outcomes with a 74% increase in the rate of deaths in these patients. And significantly, this is much higher than what was expected from hospitalized patients with acute infections, even with things like sepsis, which have high rates of blood clots. They're around 15%. So what's causing this? Well, as we were talking about before, it's still being understood. And indeed, we've seen in blood results, there's elevated levels of fibrinogen, D-dimer levels, CRP, and a prolongation of PT and APTT. And D-dimers specifically have been hailed as perhaps a useful prognostic marker. And there's been debate about whether these can be used as a method of stratifying patients to different treatments, especially with regard to anticoagulants. And a few of the studies that I looked at did this. What about the mechanisms? Well, we definitely don't have time to go into those today, but it's basically a mix of factors. It looks like it's a combination of endothelial dysfunction, a complement cascade, which can cause a cytokine storm, and also just normal factors that affect hospitalized patients, such as immobilization, ICU admission, and risk factors that increase clotting like age and obesity. So my aims for the project were to examine the effectiveness of anticoagulants in reducing mortality and morbidity in COVID patients. So quite early on, in about April, lots of hospitals across the world were using anticoagulants, although the protocols really differed depending on speciality and which hospital we're talking about. So I want to see whether they're any good. And I also want to look at whether it was different comparing where anticoagulants were given. So an ICU compared to on the wards, and when they were given. So what about people who were going home on anticoagulants? And I also want to look at the kind of risk benefit analysis. So were people bleeding with these anticoagulants? So sorry, I've got lots of animations here. This was my PRISMA flow diagram. And overall, I had 11 studies. And this was what we call best available evidence, which meant that there were no RCTs included, sadly, at this time, because we were thinking this was back in June, July, when it was very early days of coronavirus and studies were coming up very quickly. So yes, we'll come on to the quality later, but it's quite an important factor in my study. And that also meant that I had to include, a very big inclusion criteria. As you can see, it's not very specific, which kind of affected my results. And this is the kind of characteristics I saw in my studies. So altogether, over 10,000 patients. The studies varied from 6,000 to 26. Mostly they were from developed countries, got USA, China, Italy, France, one from England and one from Spain. And we saw that heparin was the most common drug used in all of these studies. And this is because of its anti-inflammatory effects, which are useful in COVID as well. They were all retrospective and observational, so not the gold standard of evidence. And they were all in hospital. So what did I find in the quality assessment? So this is interesting. I used a Newcastle Ottawa scale to grade on bias, and then used the grade quality assessment you can see here. So 5 of the studies were rated as, out of the 11 studies, were rated as very low. And this was mostly due to a lack of external validity. They were small, and there wasn't appropriate statistical adjustment for any of the confounders. So the kind of confounders I wanted them to adjust for were things in this is a Padua risk score, which looks at a risk of clotting, as well as age, gender, and chronic anticoagulant use, as well as other medications used. 5 of the other ones were rated as low. So these did adjust for some of the confounders, such as age and gender, and were usually multi-center, so it had more patients and hospitals included in them. However, a lot of them lacked a protocol, so we don't know why people were in the treatment group and people were in the non-treatment group. Basically, there was a lot of missing data, and only one of them, as you can see, was rated moderate. This was a very well-described study, and it used thousands of patients. I think it was a 6,000 patient one, and it adjusted for confounders such as age, sex, chronic anticoagulant use, and disease severity. However, it was only in the ICU, so it wasn't very generalizable. Okay, so what do we find? Well, I'm not going to go into too much detail, it's time, but overall, the data suggests that anticoagulants versus not using the anticoagulant was beneficial for patient outcomes. You can see there were 6 studies here that looked at this primary outcome. However, I commented that the overall certainty of this evidence was low, and this is due to the kind of the critical and high risk of bias in many of these studies used, and they were very limited in numbers and generalizability. Although it is worth noting that now most hospitals are using anticoagulants, prophylactic anticoagulants for patients hospitalized with COVID. And onto my secondary outcome. There were even less studies here, so 4 studies looked at this. And overall, I said that therapeutic anticoagulation cannot be recommended over prophylactic anticoagulation. This is because of the small number of studies and the questionable external validity of all of them. It does provide some suggestion of an association between higher dosage of thromboprophylaxis and better outcomes in critically ill patients. So you can see the ones in the ICU are the ones that are showing an advantage. However, before we can recommend this, we need to have a look at the risk-benefit analysis. So only 2 of these studies looked at bleeding rates, and they did show an association between therapeutic dosage and increased bleeding rates. However, it wasn't statistically significant. So only 2 out of the 11 studies looked at bleeding rates, and none of the studies looked at the use of anticoagulants after discharge. So we couldn't comment on that, sadly. So what do we need? Well, randomized control trials, which is the gold standard of evidence. And luckily, there are a lot of randomized control trials on the way. Put here, all of these. And indeed, last month in the Lancet, a randomized control trial from Brazil, which looked at over 600 patients with therapeutic versus prophylactic anticoagulants for patients with high D-dimer levels, found that there was no survival benefit for therapeutic anticoagulants. And in fact, there was an increased bleeding risk. So that kind of indicates there isn't a survival advantage. So overall, my study suggests out of these 11 studies, there was an early indication of the usefulness of prophylactic anticoagulants compared to no anticoagulants for hospitalized patients with COVID, and perhaps some clinical benefit of higher dosages in critically ill patients. However, we await the gold standard evidence from the randomized control trials before making any concrete recommendations, and hope they will shine a light on the risk and benefits of anticoagulants in terms of bleeding. Thank you very much.
Thank you so much, Manon, for a fabulous presentation. and really keen to hear your thoughts about next steps. I just remember coming up with this idea following one of the RRG meetings, and very keen to ensure that some of this work gets out in terms of publications.
Yeah, I should say I've updated it now, so I didn't, because I haven't quite finished it, but I've now got 11 more studies in my systematic review, which kind of say a similar thing.
Yes.
But a bit more evidence backing it. And yeah, sadly, the randomized control trials are only just coming up now, because obviously it takes about a year to be properly conducted. So
thank you. And I know just to start the questions off, the different settings are quite important, if I remember rightly, Manon. And I didn't know if you wanted to chat about that.
Yeah, so it seemed that this was in terms of the higher dosage of anticoagulants, so mainly the heparins. And if the patients were more critically ill, we could see more of benefit for taking the high dosages, which is in kind of in line with normal hospital guidance, I think, because these patients are at risk of blood clots anyway, especially if you're on a ventilator and immobile for long periods of time. So yeah, they kind of saw the most benefits of having anticoagulants, especially the kind of intermediate or therapeutic dosages in terms of preventing blood clots. Yeah.
Thank you. And in terms of the core components of the diagnostic arm, because you mentioned D-dimers, was that the only diagnostic element that you found that was useful?
D-dimers in the studies was the most common thing that was used to kind of decide whether patients were going to be on anticoagulants or not on anticoagulants. But other things that we used were kind of already established risk scores. So I don't know if you've heard of there's a Padua risk score, which I put on my presentation. That was used. Although, however, I must say that a lot of the studies didn't comment on why the patients were on anticoagulants or weren't. Some of the studies were done, as I showed before, like quite poorly. There wasn't a lot of information. So it was quite hard to interpret or not interpret why patients were doing well.
Thank you. Graham, did you have a question?
Yeah, just well, a comment and a question. I guess early on in the pandemic, did you find any changes between what phase of the pandemic you looked at? Because I certainly, a number of my clinical fellows early on in the pandemic down in London were treating COVID as sort of acute respiratory distress syndrome, which is classically, sort of sepsis, shock lung, which is linked to capillary leakage. And so what you do is you massively dry the patients out, and they're all going to renal failure and getting clots. So I wonder how much in the early days plasma viscosity contributed to an increased link of, an increased preponderance of VTE. And I guess it's quite hard, isn't it, as the standard of care changes so quickly, to get a sufficiently powered cohort to answer that question. That's the question. And also, I don't know if you're aware of, I know some folks in biology, medicine and health have done some work looking at von Willebrand factor and Adam TS13 imbalance. I think Stuart Allen was, that was one of the RRG, whatever we called it, outputs. That I don't know if you've seen that or whether you think that has any relevance. It's still in medical archive, but if you've not seen it, I'm happy to post the link in the chat.
Yeah, I did see some things about von Willebrand factor. I've got to say, some of it did go over my head because I'm not a hematologist. But a lot of the studies commented on the fact that if they'd done it over a few months, the kind of practice was changing. Yeah. So that was one thing to look at from the studies, whether they kind of adjusted for that difference, which few of them did not. And the difference in between the two of the studies were from Wuhan in March. Like, they were getting no anticoagulants compared to the ones that were done in June, where there was already protocols out there and people had more knowledge about what was going on with the COVID and the changes in blood vessels.
Thank you. Sean, would you like to ask your question?
Yeah, hi. Yeah, I was just wondering about comparing these patients in your trials to patients that contracted COVID that were already on anticoagulants for other issues and had been on them for a prolonged period of time.
So yes, I didn't get time to comment on that, but 2 of the studies focused on patients on pre-admission anticoagulants. And I think the original hypothesis was that they might have a higher mortality, people who are already on anticoagulants. However, they actually found the converse result in these 2 studies, and that they were kind of protective against mortality or morbidity. Yeah, there was one done on patients with DOACs who were over 70 years old, and they had a decreased rate of death. And then the other one found no significant survival advantage, but no disadvantage of being on anticoagulants, when you might think they were at higher risk of death because they had these chronic comorbidities like cardiovascular diseases.
Thank you so much, Van. Another fabulous presentation, and I'd like to thank you for speaking today. Again, if there's questions in the chat, hope you can answer some of them in the chat, please. And I'll move on to Katie. Katie, the floor is yours.
Thank you. Is that working? Sorry.
Yes.
Yes, great. So hi, I'm Katie. I'm a GP trainee in Manchester. I think it was a few years ago now that I was a student at Manchester University doing the MRes. And Angela Spencer was my supervisor. And after I qualified, we worked together on my dissertation and adapted it, and then we got it published earlier this year. So it's a full systematic review into the effect of cognitive behavioural therapy on mental health symptoms in child refugees. Oh, not clicking on to the next. Sorry, there we go. So just to start off simply, the definition of a refugee. This is a definition coined by United Nations Convention in 1951. So it's a person who, owing to a well-founded fear of being persecuted for reasons sorry, I've got some reverberation there. Well-founded fear for being persecuted for reasons of race, religion, nationality, membership of a particular social group or political opinion, is outside the country of his nationality and is unable to, or owing to such fear, is unwilling to avail himself of the protection of that country. And asylum seekers are simply people who've got their application process in and they are awaiting the outcome. So for the process of this review, we combined refugees and asylum seekers because we felt like their life experiences and the resulting mental health problems are actually pretty similar in these 2 groups. So global background. Global displacement in 2020 actually led to 26.4 million refugees and asylum seekers worldwide, and over half of these were children. And these children have experienced multiple stresses and traumas. So that could be the original trauma they were fleeing from, such as war. It could be the trauma of the journey, such as living in a refugee camp or unsafe transit. But it can also actually be a trauma when they get to their destination, in terms of being put in a detention centre or the cultural shock when they arrive. So, and we actually know that up to 80% of these children do have psychiatric symptoms, which are most commonly depression, anxiety, and post-traumatic stress disorder, or PTSD. So despite this really high morbidity rate, the health service utilisation in this group is really low due to the barriers they face. So any treatment options for this group need to be really easily accessible. So a bit about cognitive behavioural therapy, or CBT. It's a talking therapy which focuses on changing unhelpful cognitive distortions and behaviours with the aim that this will improve emotional regulation and coping strategies. And it has actually been used for mental health symptoms in other traumatised child populations, such as children who were involved in 911 and children who have been involved in natural disasters like earthquakes. Yet the current evidence based on CBT in child refugees is sparse. At the time of writing this, there were randomized controlled trials, which were showing promising results, but there weren't any other systematic reviews of CBT in child refugees. So hence the main objective, which was to assess the effects of CBT on symptoms of depression, anxiety, and PTSD in child refugees and asylum seekers. So the first thing we did was develop the search strategy, so the PCOS. So the population were children, refugees, and asylum seekers under 18. The intervention was CBT of any form, any variety, in any setting. We only included groups that had a between subject comparison or within subject comparison before and after CBT. We only included studies that had mental health scores measured on a validated scale. Study design, we did actually include all studies because we were imagining, well, from a scoping review, there weren't going to be many studies out there. And then we did a systematic review of 5 databases. This was the search output. So in essence, we screened 452 abstracts and then 83 full text articles, and we were left with 17 studies that were suitable at the end. So the next step was assessing the methodological quality, which is obviously really important in a systematic review, to know that you're combining like with like if you're trying to create an overall sort of summary statistic. And Cochrane actually advises against using numerical scales. It says there's a lack of empirical evidence for numerical scales. So it says instead it's better to rate studies as high, low, or uncertain risk of bias against certain domains. So this is what this infographic is showing. The domains along the bottom, so you've got like randomization or intention to treat. And then the studies are along here. But so you can see at this point there was quite a wide difference in risk of bias. You've got some studies that are quite low and some studies that are quite high. So at this point we decided it wasn't valid to do a meta-analysis because we weren't combining like with like, and the studies were quite different in their design as well. So yeah, that's why we decided not to do a meta-analysis at this point. So the results, so in the 17 studies, in every single study, the mental health symptoms got better after CBT. And that was statistically significant in 12 of the studies. And in 9 of the studies, that brought the reduction in symptoms down to subclinical levels for those children. 5 of the 7 studies that had a follow-up period, the improvement was maintained, and that was up to 1 year and 2 years in some instances. But in contrast, in the majority of control groups, the symptoms all got worse over time. So that goes against maybe time was a healer for these children, as it didn't seem to be for the control group at all. And there weren't any adverse effects of CBT identified. So a few discussion points. So this was the first systematic review to focus solely on CBT outcomes in child refugee populations. And despite the fact that CBT was given in very different places and different styles, different formats, the results were unanimously positive. And there were improvements in depression, anxiety, and PTSD. PTSD was actually the symptom that showed the most improvement. And often the CBT was carried out in schools or in group settings, and quite often the teachers and the social workers have been given extra training. So this kind of shows that task shifting can work for this therapy. And if the CBT can be carried out in school and in a group setting with task shifting, then that could be really accessible and affordable therapy for these children and for the healthcare systems providing the therapy. However, as I kind of mentioned, quite a few of the studies did have a high risk of bias. So need some caution interpreting these findings. And that's a limitation of the study, the risk of bias in some of the studies. And another limitation was that most studies excluded children who had severe mental illness, and they also excluded children who didn't speak the host country language. So further research, definitely need more methodologically rigorous CBT studies in this population. Need research of children who are on the more severe end of the spectrum. And there seemed to be a lack of culturally validated screening tools for mental health in this population, so that more research in that area is needed. Thank you. Any questions?
Thanks so much, Katie. That's fabulous. I just wondered if I could ask a quick one. How did you feel the MPH helped you take your dissertation? Let's start with you.
Oh, someone's got a baby.
Yeah.
Well, it was a
Take
gift
your
of
Oh, sorry.
It's all right. I'll say it was a gift of Angela Spencer, probably. I don't know about a supervisor. But also I managed to tailor like some of the modules that I did to help me to do the systematic review. So that just gave me a bit of grounding to be able to make it into a full systematic review that was good enough for what the publishers wanted it to be, which it wasn't when it was a dissertation, and then I had to do quite a lot more work on it.
Brilliant. And congratulations on all your successes. And I know we have, do you want to stop sharing your screen?
Yeah, sorry.
And we have a question from Annie, and I didn't know if Graham has a question as well.
No, I was just going to say a fantastic piece of work. And are we implementing CBT in the refugee population in Greater Manchester? And if not, why not?
Very good question. No, not that I'm a GP trainee, so I do work in primary care, and I have not seen any referral pathways that we can use. It's possible if a child can actually get to CAMS, then they might get CBT, but that in itself is a massive issue at the moment in Manchester. Sorry, child and adolescent mental health. Yeah.
Because I mean, could you send me the link for that, or could you post the link to the paper? Because I'm not actually sat on it yet, but I was asked. There's a healthcare worker sort of refugee charity, I think, that's run out of Salford, that actually you may know about, our partner, that I was asked to sit on the board of, and I've not been to my first meeting yet, but I've agreed to sit on the board, and that it might be a good place to bring it up there. If you know, you can have a bit of local influence if you send me that.
Is that Rebecca Farrington's
I think
old
so.
practice? Yeah.
Yeah.
Yes, yeah. I can email it to Apana.
Yeah. And Graham, just to add to that, it was part of the Bill Backfairer presentation as well. So good. Sandeep, I think, is leading on that piece of work. So I could send you my notes from there, because it's that unmet need that I think is so crucial at the moment.
Yes, no, I agree. And I suspect it will become, sadly, an even larger challenge as well.
Yeah.
There's actually a massive handbook that already exists, like someone has made it, which is how they trained all the teachers and social workers in the studies. So that already exists, and it's free, available online. So a lot of the work's already been done. Yeah.
Yes, I guess it's the challenge of funding and implementation, and uptake is always the final yard, or final 10 miles, or whatever they call it. The final mile is always the hardest, isn't it?
Thank you. Annie, would you like to ask your question?
Yeah, I was interested in, I thought it was a great presentation, well done. You said that the control group, their mental health declined during that period. So I was wondering whether that suggests that CBT had a bigger impact if overall there was there might be an expectation that the child's mental health would decline over that period, and they had an improvement. Does that suggest a greater improvement?
Yeah, you're right, actually. I hadn't thought about that slant on it, but actually, yes, potentially, because if their symptoms had just stayed the same, then that would have been an improvement in itself, wouldn't it, than getting worse. So yeah, just to say, the children who got worse over time, the way they dealt with it ethically is they were on a waiting list for CBT. So they did eventually get CBT in all the studies. But yeah, you're right, possibly an even greater impact.
And there's also quite a lot of online CBT programs, which might be more cost effective if face-to-face work isn't can't be funded.
Yeah, definitely. Again, it's hard to get funding as a GP trainee. It's hard to get free access for patients who can't afford it at the moment, but that would be great, wouldn't it?
Yeah.
I wonder if some of the benefits of the group work were actually that the children were interacting with children who've been through similar experiences as well, in addition to the CBT, so that would take away from that a bit, but yeah.
Thank you, Katie. I wondered if we could ask you to answer Tom's question in the chat, Katie, if that's okay, and just to say thank you again for an excellent presentation. Alex, can I give you the floor for your presentation now?
Yes, of course. I'll just start sharing my screen. If you let me know when you can see it.
Not yet, Alex.
Oh, perfect. Let me just try and share again.
Brilliant. Thank you, Alex. Over to you.
Perfect. So for my dissertation, I did a systematic review looking at the cost effectiveness studies for the use of Abbott's Freestyle Libre among patients with type 1 diabetes. So just to give a bit of background on this, because I'm not sure how familiar people will be with type 1 diabetes. So type 1 diabetes is where individuals produce very little to no insulin. Now, insulin is responsible for regulating blood glucose levels. So obviously without this, there's a potential for vast variability in blood glucose levels. So it can go quite high, which is linked to several outcomes such as neuropathy, kidney damage, nerve damage, things which happen over a long period of time. But then on the other end of the spectrum, if blood glucose levels go too low, there's the risk of mortality and then also hospitalization if it's left untreated. So part of the central to the disease management is to make sure that blood sugar levels are monitored regularly. Now, the main way of doing this is through finger prick testing. However, there's quite a few barriers to this. So it could be that people have workplace barriers, or maybe there's a pain or discomfort or embarrassment around that. So what has been found is that patients aren't always compliant with recommendations to keep on top of monitoring the blood glucose levels. So what Abbott did in 2014 is they brought out the Freestyle Libre, which you can see in the middle here. And it's a small sensor, which is worn on the back of the arm. And it helps to overcome some of the barriers traditionally associated with measuring blood sugar levels and keeping control of the disease. So what they did with that is the individual can scan rather than pricking the finger, and it also shows the direction of blood sugar, whether it's moving up or down, and it had improved clinical outcomes for patients, so they experienced less hypoglycemia, and then also more longer term outcomes such as HbA1c were also reduced. But there was a small barrier with this, and more from the health system perspective, in that compared with standard finger prick monitoring, the Freestyle Libre is actually quite a bit more expensive. So I've given the example here from the UK on the bottom. So every 2 weeks, the Freestyle Libre through the NHS would cost £35 per patient, whereas standard finger prick monitoring costs around 12 to 15. I know this range shows a little bit wide, but it tends to focus on the lower end of the spectrum. So obviously, if there's quite a lot of patients with type 1 diabetes, it's important for the health system to decide whether this is actually a cost-effective use of public money. Obviously, not just for the NHS, for wider health systems as well. So when I started looking at the evidence, I noticed that there was a gap in the literature and that there'd been a few economic evaluations conducted, but there wasn't any recent systematic reviews which brought these together to obviously determine whether it was a good use of public money or not. So this was the main aim of my research going forward, and it was to bring together this evidence and, like I said, see whether it would be a cost-effective recommendation or not. So I'll just move on to the next slide, which shows the process. So firstly, I started out by making an eligibility criteria. And for me, the main eligibility criteria was that it needed to be a full economic evaluation, and it needed to compare the Freestyle Libre with traditional finger prick monitoring, as opposed to some of the other methods, such as continuous glucose monitoring. There were some restrictions, such as English language, and also date restrictions, because obviously it didn't get brought out until 2014. So I really concentrated on literature beyond this date. So once I'd done that and created search strings, the next step was for me to actually do the literature search. So this was done across Embase, Medline and PubMed. And once I'd actually looked and obtained some literature as well, hand searches of the references of relevant literature were also searched. I also got in touch with Abbott, who manufactured the Libra, to see whether they were aware of any upcoming literature that was maybe in research or not been published yet. And then also some of the key authors were contacted. So once all of the literature had been obtained, I downloaded this into an Excel file and then did a dual screening process, first of the title and abstract, and then of the full text. And then obviously a quality assessment was performed. And this was done using both the NHS EED handbook and the Cheers checklist, which you'll probably be familiar with if you've done the health economics module, but if not, it might be a bit new. So from my search, so there was 111 potentially relevant publications identified, which I'm aware compared to some of the other systematic reviews out there is relatively small, but I think this was due to it being such a new device. But actually, when I'd gone through the screening process, it got to a point where there was actually just 9 publications which were deemed potentially relevant in the end. However, 5 of these were actually abstracts, and as you're all probably aware, abstracts are very short, around 300 characters, 500 characters usually. So there wasn't enough detail within these for me to include them, but instead I've included them in the appendix just to support the main findings of the other publications. So from the 4 full text publications which I identified, 3 of these were model-based publications and 1 of them was a trial-based publication. Now, both of them relied on quite small sample sizes. So the 3 model-based publications all obtained effectiveness data from the MPH trial, which was a big trial. Well, I say a big trial, it was actually a small trial on effectiveness, around 100 people in the UK. And then the other trial was around 60 people in Spain. So I'll move on to the outcomes from these publications. So they were quite varied. So for the model-based publications, they measured outcomes in terms of quality-adjusted life years. Now, these range from 0.5 to 2.2 or 2.1 quality gains over the lifetime, which was around 50 years that the models were run for. So obviously, it's quite a bit of variability there. And also in terms of the hypoglycemia reduction, which was the low blood sugar, which I spoke about, the reduction ranged from 25 to around 60%. So again, quite a wide range. In terms of the costs and the cost difference between the Freestyle Libre and the standard blood glucose monitoring, again, the costs were quite varied and it ranged from around £400 to £1,600. Now, the reason for this, some of it was just due to differences in model inputs and then just differences in the cost of the device between different countries, and also differences in whether they included the cost of insulin within the publications. So in terms of the outcomes, the actual incremental cost effectiveness ratio, which is the measure of the outcome, ranged from 2,500 to around 25,000 per quality adjusted life year. So as you can see, it's quite a big range there. But despite the variability in all of the outcomes and despite the variability in the costs and the qualities, actually all of the publications did deem that the Freestyle Libre was cost effective because it all fell below the willingness to pay thresholds which had been reported for the respective countries. So even though there was this big variability, it was still a positive outcome for the Freestyle Libre. And then again, all 5 of the abstract publications had this same finding that yes, whilst it is a little bit more costly, it's worth doing when you consider it in terms of the benefit for the patient. So just a quick roundup from the summary of the quality assessment. So these did seem to be very robust publications. So the methods were really well described and they're taking steps to ensure that the findings were robust. So sensitivity analysis was performed in quite a few different variations as well. So for instance, scenario analysis was performed whereby they put a different scenario of if it hadn't had a good impact on hypoglycemia, would it still be as effective? And even though they did all of these different scenarios, it still came out as cost effective. So we could be very confident in the conclusion that yes, the Freestyle Libre did seem to be cost effective with managing patients moving forward. And also things such as the cost data, it was all obtained from reliable sources. They were really well explained, the methods for obtaining costs, and then any reasons for any assumptions were also well documented. So this was really good. However, there was some weaknesses across the different publications. So one of the biggest ones is obviously the generalizability of the findings. They were all all of the effectiveness was based on a small trial from either the UK or Spain. And there might be differences with patients in different countries or how they manage the disease. Also, thinking back to the model publications, which all relied on this one evidence base, which was this impact trial, there was an over-reliance on this one study. And then obviously, if there were any issues within this study, this would be present across all of the evidence base, which I think this was mainly due to the timing really of the publications and the fact that the device was so new. But when I did look into it myself a little bit, there were some other effectiveness publications out there as well. So it would have been easier for them to also try and incorporate this as well. So then thinking as well, Abbott also sponsored all of these studies. And as we're aware, when industries do sponsor a publication, they are more likely to try and push for it to be published if it's a positive finding. So this also could have been an impact on this. Obviously, it makes sense that Abbott were sponsoring the studies because it was in their best interest with it being cost effective, but this was something to consider. So taking all of these findings, obviously it seemed that there was strong support for the cost effectiveness. I think moving forward, just to strengthen the recommendations, it would be really useful if they did expand it to wider populations. So for instance, the impact trial and the trial in Spain, they were all conducted in adult populations. And the thing with type 1 diabetes is it tends to occur during childhood and in teenagers. So it would be good as well to have these studies, then we could more confidently say that it is cost effective across a wider population who are likely to benefit. Then obviously just making sure the evidence base is a little bit bigger. And then one of the studies who didn't do sensitivity analysis, I think that's very important. So I think for future research, it's just important that we try and obviously make it as robust as possible.
Thank you so much, Alex. Are you okay to stop sharing and we can?
Of course.
Thank you. Another excellent presentation there. I'm embarrassed to say my first research project was CGMS in our diabetic population 25 years ago. So just shows how old I am. Graham, is your hand up for a question?
No, I was just going to say, fantastic talk, and it's great to see things like this. I do a sort of a pancreas and islet transplant clinic, so my real world experience as a doctor is that patients absolutely love them, and they like the Libre 2, which is, someone's mentioned it in the chat as well, which is got Bluetooth. I think that's the main difference.
Yes, it does, and it's got alarms as well. And then even now they're bringing out the Libre 3, which is a little bit smaller, which I think is mainly for cosmetic reasons. But I think when they're still valuing this among the patients, they're still probably going to value it a bit higher as well. So
yes, and I think you're right. This sort of long-term outcome, it's going to be quite hard to disaggregate, as we were discussing before, about changing standards of care, because diabetes treatment has just been, over the last 5 to 10 years, has just been unbelievable. It was always to have a bit of mixed up insulin and that was it. And now, you know, you've got pumps and sensors and, you know, all, you know, different types of insulin, and it's just quite extraordinary. And my own observation is that, particularly around the hypoglycemic unawareness, which is one of the main indications for islet transplantation, actually we're hardly doing any single islet transplantation now, because all people needed was good diabetes control. So of course those numbers are quite small, but it's more than anecdote that actually if you prevent hypos with alarms, particularly if people have unawareness physiologically, it can save them from having to have a transplant and immunosuppression. So it's, you know, there are some very immediate term benefits to this type of monitoring, and it's
definitely
great.
I think even today, as like we're doing this presentation, I think they're trialing the first closed loop systems for type 1 diabetics in the UK, so it's very exciting times for the technology.
Yeah, thank you.
Thank you, Alex. I'm going to ask Paula if she wants to come in.
I think Sian and Annie might have answered my questions. They've got a lot more knowledge about diabetes than me. I was just wondering about insulin pumps and where that fits in, and if that changes the cost effectiveness? You know, if someone's using an insulin pump as well, does that reduce the cost effectiveness, or does it actually increase the cost effectiveness because it's that closed loop system you were talking about? And did any of the studies look at that? Do you know how many of the participants were using a pump as well? And how have you seen cost effectiveness results for other continuous monitoring? And how does that compare? Are they all pretty much similar, or is there something particularly good about the freestyle?
Yeah, so the closed loop system currently isn't there yet for the Freestyle Libre. The impact trial did, I think it had around 30 to 40%. I would need to double check the facts, but I think they did have some people on insulin pumps as well. And obviously it doesn't impact the way that you monitor your blood glucose levels in the respect to, unless you've got a closed loop system, like we said, it wouldn't have had an impact on the cost effectiveness there. In terms of looking at other continuous glucose monitors, I know there's like the Dexcom G6, and I think one of the main issues is that there's it's quite a substantially higher initiation cost for the Dexcoms, and it's more of a continuous cost as well. So the big difference is the cost difference. So whilst there is the cost difference with the Freestyle Libre and standard care, the cost difference between the Freestyle Libre and things such as the Dexcom is even greater still. So it makes it even more difficult to demonstrate cost effectiveness for these other continuous glucose monitors, if you will.
Brilliant, thank you. That's interesting because I've seen the Dexcom 6 being promoted widely directly to patients. So it's interesting to know it's more expensive.
Yeah.
Thank you. And Annie, were you going to give us a user's view?
Yeah, I mean, I was very resistant to using the Libre. I don't know, Alex, are you also?
Yeah, I'm diabetic. I've got a Libre on now.
Yeah, me too. I was very resistant to it. I've got one there. Because of the idea of kind of having a device on my body, but and you also have to get used to the different. It doesn't read your blood sugar quite the same as a.
Yeah, it's not as accurate.
Yeah, it's not as accurate, but
yeah,
you know, once you've got used to that and kind of compensate for that,
yeah,
it does make life a lot easier.
It does make it far, far easier. And I think the only thing I was maybe apprehensive about is people do sort of use it as an excuse to come up and like, oh, what's that? But I think once you sort of get used to the questions, it's fine. And I think obviously with them making the Freestyle Libre 3 smaller, like I said, it's probably going to be an even bigger benefit for patients because it's easier to hide, or if they wanted to hide it, it's more discreet.
Thank you. Sean, did you want to come in?
No, I've not got any questions. I was just adding to the chat with a bit of info that I've got on costings and what's coming up and things like that. I say only because my son is a type 1 diabetic and we've been through all the hoops and jump tests that you have to do to get one.
Thank you. So Alex, I know we have Gemma here, and I don't want to put her on the spot as our health economist on the masters, but I think one of the key things about systematic reviews is that synthesis of economic analyses, and Gemma's PhD is just fantastic. Gemma, did you want to come in at all?
Oh, I'm really biased because I'm her supervisor. And we're working on a publication at the moment, aren't we, Alex?
Yeah.
And I think it's great. I think there are limitations of the evidence feeding into the models, but I'm generally a more negative, skeptical person, so to have a balance.
Yeah, we've got a good balance there then, Gemma.
Yeah.
I think on that note, I really wanted to thank you all, because just being old, I think it's just fantastic seeing how our lecturers are supporting our students to get our publications out, and the quality of the dissertations is just phenomenal, and having the ability to be your programme director and watch you all grow and see this phenomenal amount of work is just really exciting for me personally. And you're going to be the next generation of students, and we hope you'll choose us when you're choosing your PhDs. I'd like to also thank Graham, and I didn't know, Graham, if you had any closing words before we move on to the next session.
No, I mean, I'd just like to say it was I was really pleased I was able to keep and listen to all of the students and the fantastic work that they've done. I've been able to keep my emails going on in the background, so I'm really happy I was able to stay. I didn't think I'd be able to, and my time was well rewarded. Fantastic set of very sort of diverse presentations, and I think you know, the Masters in Public Health and PhD students to come is safe in Manchester's hands. So I'm very pleased that that this is part of the faculty, and I look forward to seeing all the publications and the work that's going to come from it. Well done, everybody.
Thank you. So thank you, Graham. Thank you to our speakers, and most importantly, thank you to the delegates. I'm going to hand over to Greg about the organisation of the next session.
Yeah, so, oh, sorry. Oh, I just jumped in too quickly. You go, carry on.
Go on, Greg, you go.
I was just saying, obviously we're slightly overrun, but if all MPH students and tutors can go into the alternative Zoom, I'll put it in the chat. And also thanks to the presenters, and hopefully you'll still be able to join us so that getting on to the nitty gritty of doing your dissertation, our current students can ask your experiences for tips and advice, and Roger will lead that session. So once Apan has closed this, we'll close this session and open up the other one.
I was just going to say about your daily digest and how useful it is, and that can all be found on our programme. So we look forward to seeing you in the next session. Please have a look at the programme for all future sessions, and thank you so much for all of your help and hard work. Thank you.